Imagine you suffered a sports injury in your 20s, like, say, a minor tear in your knee ligament.
Oh, sure. Very common.
Right. And you go to physical therapy, you do your exercises, and eventually it heals up enough that you just completely forget about it. I mean, it doesn't bother you when you run. It doesn't ache when it rains. You literally go decades without a second thought.
Yeah. Your body just compensates and you move on.
Exactly. But then, out of nowhere, right around your 50th birthday, that exact same knee joint suddenly completely gives out.
Like total failure.
Right. It buckles, it swells up, and it leaves you barely able to walk, which honestly makes absolutely no mechanical sense. Structural injuries don't just, spontaneously reactivate after 30 years of total stability.
They really don't. Not on their own.
Right. But we are going to explore a physiological failure today that defies that basic logic entirely. So, welcome to the deep dive. Today's mission is to answer a highly specific, but actually incredibly common question for you. Can the drop in estrogen during menopause take a previously manageable, maybe even completely unnoticed pelvic organ prolapse and suddenly make it significantly worse?
It's such an important question because we are looking at a phenomenon that completely upends how we usually view structural wear and tear in the human body.
So we have a really solid stack of sources for this today, right? We're pulling from the official clinical guidelines from NICE and the British Menopause Society, patient resources from the Pelvic Obstetric and Gynecological Physiotherapy Network. And
POGP, right?
yes, the POGP, plus a massive Cochrane systematic review, and this really fascinating molecular study from Spandito's publications that actually looks at what happens to your tissue on a microscopic level.
Yeah, that Spandito study is incredible. And this is far from a niche issue, by the way. We are talking about a condition that affects 50% of women over the age of 50 who have had a child.
Wait, 50%. Half the population in that demographic.
Half.
Yeah.
Exactly. Yet the psychological weight of this condition is so heavy and, well, the stigma is so profound that medical professionals frequently describe it as a silent epidemic.
A silent epidemic because so many women are told, or they just assume that this sudden discomfort is just, a normal part of aging.
Yeah, they just accept it. They alter their wardrobes. They stop their favorite exercises. They deal with chronic pain.
Because they think there's nothing left to do.
Oh.
But, spoiler alert for you listening,
Mm-hmm.
you do not have to just live with this.
Mm-hmm.
So to figure out exactly why your pelvic floor might suddenly feel like it's collapsing,
Mm-hmm.
and more importantly, the specific tools you have to fight back,
Mm-hmm.
we need to map this out.
Absolutely, because once you connect the macroscopic anatomy, the stuff you feel every day, to the cellular biology happening beneath the surface, the whole puzzle comes together. The sudden onset of these symptoms makes complete, undeniable sense.
So let's build that picture. Before we dive into the actual hormonal shift, we need to lay out the basic mechanics of the pelvic floor. I like to think of the structure as a biological trampoline.
That's a great visual.
You have this complex interwoven mat of muscles, ligaments, and fascia, right? And it stretches out from the pubic bone at the front all the way to the tailbone at the back.
Yeah, and resting directly on top of that muscular trampoline are your pelvic organs. So you have the bladder at the front, the uterus in the middle, and the rectum at the back.
Right.
A pelvic organ prolapse, which is often just abbreviated as POP, occurs when that trampoline loses its tension. The fibers weaken, or maybe they stretch out too much, and they can no longer hold those organs up.
So gravity basically just takes over.
Exactly. Gravity takes over, allowing one or more of those organs to bulge down into the vaginal space.
But when that trampoline sags, what does the listener actually feel? Because, it's not a one-size-fits-all sensation, is it? It really depends on which guest on the trampoline is causing the most trouble.
It does. That determines both the physical sensation and, well, the clinical name. So if the bladder is the organ sinking and pushing into the front wall of the vagina, a woman might feel a constant urgent need to pee. Or she might experience stress urinary incontinence.
Like leaking when she coughs or sneezes.
Right, or laughing. That is an anterior prolapse or a cystosol.
Okay, and what if it's the rectum causing the issue?
If the rectum is pushing into the back wall, that's a posterior prolapse or a rectusol. And that often presents as a heavy, dragging sensation that inexplicably gets worse by the end of the day.
Ugh, that sounds awful.
Yeah, or a frustrating feeling of, incomplete bowel emptying. Now, if the uterus itself drops straight down, that's a uterine prolapse. And for women who have had a hysterectomy, the top of the vagina itself can actually invert and drop down.
Wow, really?
Yeah, that's known as a vault prolapse.
The daily reality of those symptoms just sounds genuinely exhausting. But it's not always a severe, immediate crisis, right? Like, I know doctors grade Gs on a scale of 1 to 4.
Yes, they do.
So a grade 1 or 2 prolapse might be entirely asymptomatic. A
Yeah.
woman might not even know she has a slight droop until, like, a doctor mentions it during a routine cervical screening.
Right. It's only at a grade 3 or 4 where the organs are physically bulging down to or even outside of the vaginal opening. Those early grades represent a compromised system, but one that the body is successfully compensating for.
Right. The structure is altered, but it's holding. Which brings us right back to the central mystery of this deep dive.
Hmm.
The biggest risk factors for that initial injury to the trampoline are almost purely mechanical.
Yes. Childbirth, vaginal deliveries, using forceps, carrying a really heavy baby.
Right. Or maybe a lifestyle factor, like a career involving decades of heavy lifting or chronic straining. But if that mechanical injury happened 20 or 30 years ago in a delivery room, why is the trampoline suddenly failing now in a woman's late 40s or 50s?
The answer lies in a condition known as genitourinary syndrome of menopause, or GSM.
GSM.
Yes. For decades, both the general public and, honestly, much of the medical community thought of estrogen primarily as a reproductive hormone. Like, its job was to regulate the menstrual cycle and support pregnancy.
That's definitely what we're taught in health class.
Right. But estrogen is actually a crucial, full-time maintenance worker for your pelvic tissues. It acts as a powerful local strengthener, moisturizer, and regulator.
Okay, so we usually think of the trampoline breaking because someone jumped too hard on it. But what you are saying is that the springs aren't breaking from a sudden new force. They're essentially rusting from the inside out because the chemical environment surrounding them completely changed.
That captures the mechanism perfectly. When menopause hits and those estrogen levels plummet, the maintenance crew abruptly leaves the site. This triggers a physiological cascade called vaginal atrophy.
Which means what, physically?
The tissues of the vagina and the supporting fascia of the pelvic floor literally become thinner, drier, and significantly less elastic.
So that grade 1 or 2 prolapse from childbirth 30 years ago, the one the body was easily compensating for, is still there. The organ hasn't necessarily dropped a single millimeter further.
Exactly.
But suddenly the tissue holding it all together has lost its resilience. It becomes highly inflamed, dry, and irritated. So that completely silent asymptomatic prolapse transforms into a highly symptomatic painful one.
Yes. The structural defect didn't actually worsen. The tissue's tolerance for the defect plummeted. The shock absorbers are gone.
I want to look much closer at that loss of tolerance, because we know estrogen acts as a strengthener, but the molecular study from Spandito's publications we are looking at today actually analyzed what happens to this tissue on a microscopic cellular level when estrogen disappears.
And the cascade of failures is wild to read about.
It really is. Let's get into it.
Well, to appreciate the scale of the breakdown, we have to look at the cross-section of the vagina, which has 3 distinct layers. There is the tunica mucosa on the surface, the tunica muscularis in the middle, and the tunica adventitia on the bottom.
Okay, 3 layers.
Right. In a healthy, estrogen-rich environment, the superficial cells of that top mucosal layer act kind of like a biological escalator. They're constantly moving up and shedding, renewing themselves every few hours.
And when they shed, they release glycogen, right?
Yeah.
Which is essentially a buffet for the lactobacilli, the good bacteria that keep the whole ecosystem balanced.
Exactly. Feeding that bacteria is what keeps the vaginal pH low, acidic, and hostile to infections. But post-menopause, the lack of estrogen grinds that escalator to a halt.
The shedding stops.
The shedding stops, the glycogen disappears, the lactobacilli basically starve and die off, and the vaginal pH rises above a level of 5.
Wow.
Yeah, this totally alters the local microbiome, leaving the tissue incredibly prone to chronic inflammation and infections.
Okay, so that explains the surface level irritation. But the real structural damage, the actual failure of the trampoline springs, is happening down below the surface in the connective tissue. This is where the study gets fascinating.
Oh, absolutely.
Let's imagine your pelvic floor is a bustling construction site. You have these specialized cells called fibroblasts. They are your builders. Their entire job, COM47, is to lay down fresh collagen and elastin to keep the structural scaffolding strong and flexible.
Right, they keep everything bouncy.
Exactly. But the Spandito study shows that when the estrogen dries up, these fibroblasts actually go dormant. They physically change shape and turn into something called fibrocytes.
Basically, the builders simply pack up their tools and go on strike. No new collagen is being produced.
The builders are on strike. But a construction site doesn't just freeze in time. You also have a wrecking ball on site to clear out old, damaged debris.
Right, you have to clear out the old to make way for the new.
Yeah, and in your cells, that wrecking ball is an enzyme called MMP1. Usually there is a site form in a protein called TIMP1, whose entire job is to keep the wrecking ball in check, making sure it only destroys what actually needs to be destroyed.
But without estrogen, the foreman TIMP1 goes missing.
Leaving the wrecking ball swinging wildly out of control, smashing into healthy support structures.
And the biological data backs up that exact visual. MMP1 levels rise aggressively, while TIMP1 levels plummet. The wrecking ball is just decimating the scaffolding while the builders are asleep.
It's a complete disaster.
It is. The researchers explicitly noted a sharp, measurable decrease in type I and type 3 collagen in the tissues of women experiencing prolapse symptoms.
And looking at the internal architecture of the surviving cells reveals even more damage, doesn't it?
Yeah. The researchers examined the cell's internal skeleton, the effectin stress fibers. In healthy tissue, these fibers look like a suspension bridge, straight, dense, uniformly arranged, ready to bear weight.
Right.
But in the prolapsed, estrogen-deprived tissue, those fibers become wavy, distorted, and just chaotic.
So if the internal cables are wavy and the builders are gone, what does this actually mean for the person walking around coughing and lifting groceries with this tissue?
It means the tissue fundamentally loses its ability to handle everyday mechanical stress. The researchers actually tested this. They put these estrogen-deprived fibroblasts under what they call a 15% tensile stress.
Which is roughly the mechanical force of like bearing down, coughing, or picking up a heavy bag. Right?
Exactly. Now, in healthy cells, an internal sensor, specifically the integrin beta-1 pathway, feels that physical stretch and signals the cell to adapt, reinforce itself, and build more collagen.
It's like a muscle sensing a weight and knowing it needs to grow stronger.
Exactly. But without estrogen, that sensor short circuits. Instead of triggering adaptation, that exact same integrin pathway misinterprets the mechanical pressure and hits a biological self-destruct button.
Wait, it self-destructs?
Yes. It initiates a process called apoptosis.
Programmed cell death. So the cells don't just fail to adapt, the everyday pressure of living literally kills them.
They undergo apoptosis, yes. And this is the mechanism behind the sudden onset of symptoms. This is why the prolapse suddenly feels infinitely heavier, why the dragging sensation becomes unbearable by 5 p.m., and why the tissue feels so incredibly fragile.
Because it is fragile.
Right. The structural scaffolding isn't just weak, it is actively degrading and dying under the forces of everyday life.
Wow. Okay, so if the body's builders are on strike and the internal scaffolding is degrading, my first instinct would be to go in there and physically prop walls up myself. Which brings us to the mechanical treatments.
The standard physical fixes.
Right. Our sources from the POGP and the NICE guidelines outline the conservative, non-surgical approaches first. The first line of defense is usually physiotherapy and lifestyle modification. Things like losing weight to reduce abdominal pressure, stopping smoking to eliminate smoker's cough, and aggressively treating constipation so you aren't bearing down and straining an already compromised pelvic floor.
And pelvic floor muscle training is a cornerstone of this phase.
Doing targeted, isolated contractions, right?
Yes, usually a set of 8, held for a few seconds, repeated 3 times a day. Many physiotherapists actually recommend tools like the Squeezy app to guide patients and keep them compliant.
Because it's hard to remember to do them.
Exactly. And the goal is to bulk up the remaining healthy muscle tissue to take the load off the failing ligaments.
But for many women, exercises simply aren't enough to counteract gravity, especially if, the collagen is actively degrading. So doctors often move to the next mechanical fix, which is a vaginal pessary.
Right. The pessaries.
These are physical devices made of medical-grade silicone or plastic, and they come in a variety of shapes depending on the specific anatomy, a ring, a shelf, a Gellhorn, or a POPY. You insert them into the vagina, and they physically act as a jack, wedging into the fornices to prop the prolapsed bladder or uterus back up into the pelvic cavity.
And a properly fitted pessary can feel like a miracle. It immediately relieves that dragging sensation and allows women to return to high-impact activities like running or jumping without fear or discomfort. I mean, it gives them their life back.
Wait, I need to stop us here because there is a glaring contradiction. We just spent 10 minutes establishing that postmenopausal vaginal tissue is paper-thin, dry, chaotic, and undergoing active cell death when subjected to friction or pressure.
Oh, I see where you're going with this.
Right. Putting a rigid piece of plastic or silicone against that incredibly fragile atrophic tissue sounds like absolute torture.
Yeah.
How does a doctor prescribe a mechanical jack without tearing the tissue apart?
That is a phenomenal question, and it highlights a major failure in how this condition actually used to be managed. If you just wedge a silicone ring into an unprepped, estrogen-starved vagina, you see severe complications.
I can imagine.
The rigid device rubs the paper-thin tissue raw, leading to painful ulcerations, abnormal discharge, and bleeding. The mechanical fix literally destroys the biological environment.
So how do the modern clinical guidelines solve this? Because obviously they still prescribe them.
They do, but you cannot separate the mechanics from the biology anymore. The UK clinical guidelines from both POGP and NICE strongly dictate that before a postmenopausal woman is even fitted for a pessary, she must be prescribed topical vaginal estrogen.
Oh, to prep the tissue.
Exactly. The standard protocol is to use it daily for 7 to 10 days before the fitting appointment to rapidly heal the tissue and then drop to a maintenance dose, usually twice a week, for as long as the pessary is used.
It's essentially fortifying the walls of the tunnel before you try to wedge a heavy support beam inside.
You are calling the maintenance crew back to the site. The topical estrogen wakes those fibroblasts back up, stops the wrecking ball enzyme, lowers the pH, and plumps the mucosal layer.
So the tissue regains enough elasticity and thickness to safely cushion the silicone pessary without ulcerating.
Yes, it creates a healthy cushion.
I want to dig into this topical estrogen because navigating hormone terminology can be incredibly intimidating. We are talking about local treatments here. Creams like Ovestin, small tablets inserted with an applicator like Vagifem 10, slow-release rings like E-string, or DHEA pessaries like Prasterone.
Yes, of options, yeah.
Right. And I was reading the British Menopause Society guidelines, and they brought up this term intracrinology regarding these localized treatments, specifically the DHEA ones. It sounds like a biological loophole around the traditional risks of hormone replacement therapy, but I couldn't fully parse the mechanism. How does that actually work?
Intracrinology is a brilliant quirk of human biology. When you take systemic HRT like a patch or a pill, the hormones enter your bloodstream and travel throughout your entire body, interacting with various organs.
Right, systemic.
But with a localized DHEA pessary, you are inserting a precursor molecule directly into the vagina. The epithelial cells of the vagina absorb that DHEA and use their own internal enzymes to convert it into active estrogens and androgens only inside that specific cell.
Wait, really? The cell is making its own bespoke hormones on demand.
Exactly. And the most crucial part of endocrinology is what happens next. Once those newly minted hormones do their job of pumping the cell and building collagen, 95% of them are inactivated right there at the site of synthesis before they ever leak out.
So the rest of the body never even sees them.
The systemic absorption into the bloodstream is virtually zero. Because of this, it doesn't stimulate the lining of the uterus. You don't have to take an added progestogen to protect against endometrial cancer.
Oh, wow. That's huge.
It is. It is considered an incredibly safe, highly targeted therapy, even for many women who have medical histories that explicitly forbid them from taking systemic HRT.
Okay, so it's a localized, safe, and logical fix. But here is where our sources throw a massive, confusing curveball into the mix.
The Cochrane Review.
Yes. I was reviewing the Cochrane Systematic Review, which, for those listening, is the gold standard database for medical evidence. This specific review was updated in June 2022, looking at 14 different studies involving over 1,000 women. And it concludes that the evidence for estrogen therapy treating pelvic organ prolapse is very uncertain.
Right.
They point out small sample sizes, a high risk of bias in the studies, and explicitly state they lack solid proof that it works for POP. If the gold standard Cochrane Review is throwing its hands up, why are all these clinical guidelines NICE, the BMS, the physiotherapist, aggressively making it the cornerstone of their treatment plans?
It looks like a glaring contradiction on paper, I totally agree. But it comes down to a vital distinction in how we define treatment in medicine. We have to separate the concept of curing the anatomy from the concept of curing the symptoms.
Okay, walk me through that difference in the context of the pelvic floor.
At its core, a severe prolapse is essentially a hernia. A ligament has physically stretched beyond its elastic limit or it's snapped. Estrogen is a miraculous hormone, but it does not have the mechanical ability to act as a winch.
It can't pull things back up.
No, it cannot physically reach down, grab a dropped bladder, and hoist it back up into the pelvic cavity. If a patient presents with a grade 3 prolapse, applying a topical estrogen cream for a month isn't going to magically pull those organs back to a grade 1 position. The gross anatomical defect remains.
And that physical positioning is exactly what the Cochrane review is measuring.
Exactly.
They're looking at the tape measure, but ignoring the patient's actual experience of living with it.
Precisely. The anatomy might not shift, but the experience of having that prolapse completely transforms. By reversing the genitourinary syndrome of menopause, by waking up the fibroblasts, thickening the mucosa, rebuilding the collagen, and restoring blood flow, you eliminate the friction, the dryness, the chronic inflammation, and the microtearing.
You make the prolapse manageable.
Exactly. It might still anatomically be a grade 2 prolapse on an ultrasound, but if the tissue is healthy and hydrated, a woman might not feel it dragging at the end of the day. And most importantly, it allows the mechanical treatments, the pessary or the pelvic floor exercises, to actually function properly without causing agony.
That is such a vital reframing.
Yeah.
It's the difference between looking at an x-ray of a joint and shrugging versus asking the patient if they can actually walk up the stairs without pain.
Exactly. Symptom relief is everything.
So what does this all mean for you listening right now? The major empowering takeaway from this mountain of research is that a drop in estrogen during menopause might not be the initial cause of your pelvic organ prolapse.
Right, the injury was likely already there.
Yes, that underlying weakness in the trampoline might have been sitting dormant since your 20s. But the sudden loss of estrogen strips away your pelvic floor's resilience. It turns a quiet, asymptomatic issue into a highly disruptive, painful flare-up.
But the silver lining here is knowing the mechanism. Once you know the builders are simply on strike, you know how to call them back. You do not have to accept this sudden discomfort as just a normal part of aging.
Absolutely not. There are highly effective, deeply localized treatments like topical estrogen combined with customized pessaries or specialized physiotherapy that carry very low risk and can dramatically restore your quality of life. The tools exist, you have options, and you have every right to pursue them with your healthcare provider without an ounce of shame.
And, if we look beyond just treating the immediate discomfort, this deep dive leaves us with a really profound implication for how we view women's health overall.
How so?
Well, we have spent centuries thinking of the pelvic floor as purely a structural system of muscles and ligaments, like the dead cables on a suspension bridge. But if these tissues are actually a highly sensitive endocrine target, dynamically reacting to our hormones on a cellular level every single day, how might that completely change the way we approach postpartum care, physiotherapy, and exercise long before menopause even begins?
Wow. It makes you realize that keeping that biological trampoline bouncy isn't just about how hard you jump or how many exercises you do. It's about paying attention to the chemical environment of the springs themselves. Something to definitely think about the next time someone tells you to simply do your Kegels.